Hello students, very good morning. I am Dr. Atul Bhardwaj. Uh, Today we are going to do a topic which is going to be a very helpful topic for the beginners of ENT surgeons, especially whom have just completed their post-graduation and want to start surgical practice in their teaching field or their even individual practice as well. So let me open a PowerPoint for that. Okay, this is the presentation I'm going to share with you today. So this is my personal experiences regarding this learning curve from a PG to a consultant in a ENT practice. Which instrument you have to buy, or which books you can purchase or starts reading with. So the essence of this presentations comes from my personal experiences only, and they have been very a steep learning curve, sometimes a slow learning curve, but immensely have uh, left into a great impact as a consultant in my life. So let me uh, share the first slide. Let me drag it a little bit. Yeah. So the first question will be, when a scholar, a PG scholar completes his post-graduation, the first question arises whether he entice himself into a surgical practice or join a teaching college. So uh, the question is where to start actually your practice or a learning curve, because uh, uh, in the post-graduation, you are not able to have some, you can say, personal or uh, you can say the surgical practice you are doing or you will do in the future. The student is not well aware of where to start. So let's start from the literature. Always start with, let me take a marker first, pointer option. I will take a pen. Always start, at least you should have a basic sense of the important books of ENT literature, which initial consultant or a PG scholar has to buy. So I have started from Bellinger, and then the otological surgery famous book Shambu. And for a reference book, either you can choose between a Cummings or a Scott Brown. So these Cummings and Scott Brown are obviously, initially it was a 4-volume book. Cummings now have become a 3-volume book. It's a huge literature book, but you can say it is at par with you can say a book which you can rely upon, and it is extensive literature, even the research literature you can have, even of the topics which are not encountered in general books. So classical literature books are important. So always you have to buy a book rather than taking it from somebody. This specific topic books like migraine or dysphagias or facial nerve practices or dissection or skull based dissection, you can individually, you can bought some, the small topic book you have to purchase later on. You should not start with specific book in the early days. I will definitely going to recommend that. First of all, these basic books or these reference books are to be started off. Then you can choose upon some very specific book about surgical practice later on your life. So one major observation in my ENT practice is that you have to have at least a basic knowledge or a clinical interest or expression in the field of pulmonology, because nasal cavity and the lungs behaves very in similar manner, especially in cases like IgE responses or a nasobronchial allergies, or type 2 CRS, or you can say aspirin exacerbated respiratory diseases. So by and large, the nasal cavity behaves in congruence with the the lung tissue, or in order to have a predictive outcome of the nasal cavity management, especially in case of allergies, or either a type 1 hypersensitivity, which is a IgE mediated response, or a eosinophilic response. Both are totally different. You have to have some knowledge of basic bronchial asthma, or of a cough variant asthma, or even pulmonary eosinophilias, Loeffler syndrome. So intimately attached is pulmonology and the ENT practice. The same way is the gastroenterology. You have to have a basic understanding of a upper GI endoscopy. What are the common findings in a upper GI endoscopy? Is you have to also purchase some upper GI endoscopy atlas as well, in order to have a better appreciation of dysphagia, at least dysphagia, dysphonia, or a LPR, or a vocal cord polyp, non-angiomatous polyp, or even globus pharyngeus, or a chronic pharyngitis, which is not supposed to be infective one, and has got a close association with the GERD or GPRD, whatever you call it. So this gastroenterology component is extremely important in if you want to entice upon, or imbibe upon a surgical practice, or even OPD sense practice in a ENT cases. So pulmonology, you can have a Fishman's reference book and atlas of gastroenterology, in order to study the barium studies and upper GI endoscopies, and the changes in the gastric mucosa, which are also reflected in the esophagus itself, like Barrett's esophagus, nutcracker esophagus, and various cases of dysphasias, which has got a close association with the gastroenterology part, because by and large, in even the cases of IBS or IBD or celiac disease, the patient has got many myriad kind of presentation, especially in case of throat. So it is not, you can say that ENT practice or a throat practice is not absolutely segregated from different subjects, and you have to have a basic knowledge of of gastroenterology, in the form of upper GI endoscopy and its presentations, and like hematemesis cases. You should always go through references like LA classification, peptic and gastric ulcer, or erosive esophagitis, ulcer, non-acidic reflux type of topics. You have to always refer to the gastroenterology books in order to have a better understanding of the disease. So one of the most common is a globus pharyngeus. Globus pharyngeus is a again a subject which has to be answered through proper understanding of the swallowing mechanism, and the mechanism in which the esophagus behaves in swallowing is very important as well, in order to designate the patient as a globus pharyngeus patient, because psychiatric component is also has to be taken into consideration before going for a proper diagnosis. Apart from that, cadaver and temporal bole dissections are very important in order to embark upon the microscopic surgery and even the endoscopic surgery. So first, you have to start with the microscopic approach. I'm talking about the otology. Then you can move to the endoscopic approach, because by and large, microscopic these interventions are supposed to be having both hands free, and it's easy to learn also, and less time taking also. Whereas the endoscopic ear surgeries are because of the obvious reasons. One hand, the left hand or the non-dominated hand is having the endoscope, and all of the instrumentation hand that has to be done by your dominant hand. And so microscopic this learning curve is always is always preceding that of the endoscopic approaches. Nowadays, most of the otology procedure you can even do with the auto endoscope. So, but before going embarking onto the auto endoscopic approach, you have to have some cases done by microscope also to have a greater appreciation of the disease itself. So, temporal bone dissection and nasal cavity, obviously, you should always start with cadaver dissection for anterior fess and this ethmoidal anatomy, the configuration of the anterior ethmoidal artery, the sphenoid sinus anatomy, and the structures around the sphenoid sinus is very important to have a cadaver atlas also and a cadaver dissection also. Temporal bone dissection, I cannot stress more than that it is absolutely mandatory to have some classes of temporal bone dissection under a proper guidance in order to embark upon a otology in the field of otology surgery. So these are the prominent books which I have started from. This is Shampoo. This is Cummings, a reference book again. This is Scott Brown, and this is Paparella. These are very basic, not basic in the sense that these are standard reference book of ENT, and you can start with these books to have at least have a literary sense of the subject itself. So what instrumentation, because instrumentation in ENT is a lifelong process. You have to buy the instrument, they have got a shelf life, you have to replace them, especially the cold steel instrument. They you have to in a process of buying them time and again, and after few surgeries your crocodile forceps, especially the scissors are a little bit of blunted, and which makes the surgery much more even difficult also, and time taking also, and dangerous also. So this instrumentation buying is an intent you have to show, because without instrumentation you can't especially move in the surgical field. Not always to have the, you can start with a relatively uh, this camera equipments and other instruments which are not very costly. Obviously, first of all, you have to learn about the diagnostic endoscopy, the nasal endoscopy, the auto endoscopy. After doing few thousands of them, at least I have given an example, after doing two or three hundred diagnostic nasal endoscopy, then you can under proper guidance with a proper consultant approach having in your vicinity, you can then start in the anterior ethmoids or working in the anterior ethmoid. Same is for the endoscopic ear surgeries also. So first of all, you have to do a very you can say protracted course of learning the skill of the art of diagnostic endoscopies. Then you can move on to the surgical field. So it's a very costly affair also to arrange the ENT instrument is also very you can say a learning curve also. So also you have to have a basic knowledge of circuits and what kind of a cord the instrumentation is going to have. So a little bit of like an electrician you have to think many a times, because you have to help yourself out in majority of the situation, and not every time you are going to help with an electrician. So basic connections of uh, of different instrumentation of ENT, you have to understand which type of cords are going to fit in the proper instrument, but how you can project your images and your video recording onto different platforms, or how you can use a say data saving gadget you can use. So this is again a very initial curve of learning. So instrumentation, so majority of the OPD based practice is done by uh, a suitcase base, you can say a camera unit. It's now available as a HD camera also. You can carry it. It has got a screen attached to it, and you can fiber optic cable and a camera head. You can attach a 0-degree endoscope, the nasal endoscope, 4 mm endoscope, and start using in the OPD, because nowadays this uh, otoscope practices are almost obsolete in most of the centers, and most of the centers nowadays has got a proper camera and you can say a screen and a OPD setup, which is absolutely essential, because this otoscope days are many of the surgeons don't even use them, the otoscopes. So these are some basic instruments you have to have in your OPD. The list can vary depending upon which you are doing, but for ear there are different instruments. Nasal cavity, obviously in OPD you can only do a surveillance nasal endoscopy. Without this can be done even without anesthetizing the nasal cavity, but it's like a art you can learn from where to touch uh, where the where you have to put the instrument in your hand. You have to be very gentle also, but in many cases you have to anesthetize the nasal cavity in order to have a complete look of the nasal cavity. By and large, you can look as a screenshot, I can say, the nasal cavity even without anesthetizing it, making the patient comfortable and going just looking to the nasal cavity, whether it has got a purulent secretions or what type of metal picture the patient is having, or the patient is having a polyp or not, what is like the inferior meatus or, or middle meatus area looks like. So every patient has got a, certainly you can add up the information and definitely work upon your diagnostic skills, especially in the OPD. OPD is definitely the first thing you have to you can say make comfortable with, then only the surgical practice you can embark upon. So in the OPD it's a great learning location or a site, and every patient, if you give some time and virtually looking at the structure in each and every patient of the, you do diagnostic this 70 or 90-degree laryngoscopy in every throat patient, and you have to be very you can say uh, becomes very prudent also by learning some without anesthetizing even the throat. You can do a 90-degree or a 70-degree laryngoscopy. To be honest, from past few years we have hardly anesthetized surface anesthetized any patient of throat for doing this laryngoscopy. And we also in OPD do a surveillance endoscopy in every patient. We don't use otoscopes in our OPD now. We only use auto endoscopes and do a proper you can say documentation of each patient. So this is a basic ENT setup. You can use a camera and a screen auto endoscope. So different kind of these are diagnostic camera, need not to be very costly. And this is the surgeon's chair, and the patient sits right in front of it. Right, and if you are right-handed, the instrumentation has to be, the panel has to be on your right side. So the scholars or even the PG scholars or post PG, you have to attend a cadaver dissection courses, a short courses to have a 3D anatomical appreciation, especially of the temporal bone and the nasal cavity, which is going to be immensely helpful for your as a surgeon when you embark upon the surgical practice. So this anatomy lab visits or having a three-dimensional appreciation of the anatomy is absolutely mandatory in order to do any kind of surgery, I will say. So you can use this the CD the patient is having for understanding the three-dimensional anatomy by various softwares are available. I am using the DICOM software, which has got numerous you can say images and sections and cuts, which gives you and if you, I will give you an example. If you want to do a stapes or a middle ear surgery, then you have to have a, a software analysis of the middle ear, how the configuration of the facial is, how low lying the facial is, how much space you have got to work upon. And this adds up a tremendous amount of information and makes the surgical outcome more predictable and the surgeon more safe. The patient becomes much more, you can say, um, happy about the results also. So always you can do evaluation of the films also. You should not always rely upon the the reporting which has done with the most of the uh, this diagnostics, and you yourself have to develop a ENT surgeon. Integral part is that you have to develop your radiological skill in order to have a better 3D or three-dimensional appreciation of the anatomy, which is immensely important for, especially in cases of nasal cavity and also in the middle ear surgeries. So uh, um, this is very, very important. It's like uh, Google map for the nasal cavity and the ear surgeries. So OPD skills. You have a freezing camera, a freezing button available for with the most of the camera head. You can go close to the structure, freeze it, like you can freeze the tympanic membrane in case of minor changes like migration of squamous epithelium, why there's a granulation patch in the tympanic membrane, how is the attic is behaving, what kind of extended attic is there, or a ingrowing squamous epithelium, or a future cholesteatoma or a canal cholesteatoma. By freezing the picture, you can discuss with your friends also, and your teachers also, and you can better learn by freezing the picture. So every throat patient also, you should not think that laryngoscopy is done in for the larynx only. Let me assure you, in case of a GERD patient or a globus patient or the lumpioid sensation kind of a patient, always needs this laryngoscopy. So especially in case of a patient who are having got a mild pain in the throat or a vocal abuse, teachers, or a GRD kind of features, or a peptic ulcer patient, you have to do a laryngoscopy in every patient, I will say, of a throat patient. It will immensely help upon tracing you minor variations, how the mucosa behaves, particularly in the posterior larynx, where the acid trickles down between the arytenoid for intra-arytenoid erythema, and which leads to easy appreciable clinical picture you can document upon. Excuse me. 10 मिनट, 5 मिनट रुको भाई. Surveillance nasal endoscopy requires no LA, as it gives. The surveillance nasal endoscopy you can do without even having the patient anesthetized, and it can be done with in the OPD practice also. Make it as a habit, and you should always use a strong suction, because many of the OT has got a good setup, but the suction is not working. So at least of a quarter of a power HP suction you should use, because weak suction always frustrates you. Even the OPD and OT, always you are going to have difficulty if you use a weak suction. So next is so primarily we'll do this same learning curve topic in the second. I will make a second part of this lecture. Thank you very much for your watching. Thank you.